Hi, everybody. This is Anne Marie Hughes. I am a 10-year pancreatic cancer survivor this November. Thanks a lot to this woman and her husband, Theresa Yeo, and Dr. Charles Yeo. Welcome.
I'm Theresa Yeo. I am a surgical oncology nurse practitioner at Thomas Jefferson University Hospital here in Philadelphia. And it has been my honor to be part of the Jefferson Center for Pancreas and Related Cancers diseases for the past 13 years. This is one of the premier centers for pancreas surgery really in the world, and it is a wonderful place to work. I started working in this field about 25 years ago. At that time, the overall 5-year survival rate for pancreas cancer was 3%. This year, it's about nearly 10%. So if we could do that same threefold increase in the next 5 to 10 years, accelerating that progress, it would be tremendous. Well, I became interested in pancreas cancer when I was doing my PhD dissertation in public health at Johns Hopkins. And I was offered the opportunity to use a large database of pancreas cancer patients to look at occupational and environmental risk factors for pancreas cancer. And it also,
I did not know that.
It also helps that my husband is a pancreas cancer surgeon, and that also piqued my interest.
That's wonderful. So who came first, the pancreas or Charlie?
Charlie. Of course.
He'll be happy to know that. So Theresa, you have seen a lot of patients through the years, and I'm wondering what presentations you're seeing from patients.
Many patients have no early signs, but about a third of patients will present with weight loss, fatigue, some GI issues, and then progressing on to jaundice. But really fatigue, in retrospect, is the most common presenting symptom. One of the most promising directions in pancreas cancer is going to prevention and early detection. So the number one risk factor for pancreas cancer is aging. So there's nothing we can do about that one. But the number one modifiable risk factor is cigarette smoking. So we can do better, and we need to work harder on smoking cessation for people, particularly young people, to get them to not start smoking. Another promising approach to early detection, as you asked about, is really educating primary care providers in the country to some of those early vague symptoms. For instance, there is a recommendation out right now from a task force that's working on this to have primary care physicians be alert and suspicious of patients who are older than 65 years of age, who have new onset of diabetes, are either current or former smokers, and perhaps are losing some weight for no apparent reason. And in those patients, to have a high suspicion of pancreas cancer and to conduct screening. And by screening, we're thinking about MRI, abdominal screening, and getting some baseline biomarkers. One of the drawbacks to this approach has been getting this to get a different rating from the National Preventive Services Task Force, which is a national organization of consensus experts that issues recommendations based on evidence-based research for screening. And it's an A, B, C, D, F system. Right now, pancreas cancer screening has a D rating, meaning it's recommended against. And we have been working with a group of experts to try to get that rating changed to a C rating, which would mean neutral, or even a B rating, which would mean that they advise for doing that.
That's sinful, in my opinion, because right now there is no good blood test for early diagnostic of this cancer. And really, the way mine was caught was through imaging. And it was just incidental, which is how most people who catch it early have found it.
That's really true. We see many patients who had a scan for another indication entirely, and they see a mass in the pancreas that then leads to a workup and follow-up.
that is something that really does need to be addressed. And for our audience, we could really use some support in that regard. I appreciate that. You head up the registry of pancreatic tumors there at Jefferson. Maybe could you talk to us a little bit about what the findings are that are coming from that registry?
Mhm. Yeah, absolutely. So in 2008, just shortly after Dr. Yeo and I came to Jefferson, um, I, we founded the Jefferson Pancreas Tumor Registry, and it was based on my dissertation at Hopkins that looked at these risk factors. And so the registry is open to all people with pancreas cancer and related cancers such as duodenal, bile duct cancers, gallbladder cancers, periampullary cancers, and they're also their family members. It looks at family history of all cancers. It looks at smoking history. It asks about environmental smoke exposure, also known as secondhand smoke exposure, which is a really important risk factor, actually. It also looks at exposure to air pollution, and people don't realize that that means you're being exposed to carcinogens. It also looks at what occupation that you that you spent the most years in your life doing. And then it asks people, what have you been exposed to in the workplace? And unfortunately, most people don't know what they've been exposed to. There are over 30 well-established carcinogens that people are exposed to in their work. So and then we look at alcohol intake. Alcohol, social drinking, moderate drinking has really not been associated with pancreas cancer, but heavy alcohol drinking has been. And that means more than 6 drinks a day. One of our goals is to prevent some of these cancers. And as I said, the number one thing really is cigarette smoking. Number two thing I would say is overweight and obesity. We know that that is associated with pancreas cancer and diabetes, which goes along with that often. It really feeds a cancer. And then like to also modify alcohol intake. So that's one of the things we do. And we also identify high-risk family members. And we do recommend those people to have screening with the abdominal MRI and baseline tests, at least annually, at least once if they're young, maybe every 5 years. And particularly if they are high risk, meaning they have a family member or they have some obvious risk factors, maybe they have the BRCA 1 or 2 gene mutation, then the insurance will cover that for them. So that's part of what we do. We also have tried to marry some of that data to the tissue banking study that's been going at Jefferson for about 15 years now to identify gene mutations that are actionable targets. There are not many of them at this point, but we're still working on that. And then we also conduct annual follow-up surveys of people who are in the registry. We're looking at what their survival is. We ask quality of life questions about, what things are bothering them. This year, we asked some questions about how COVID had affected their life.
I assume that information is shared broadly and people can come to Jefferson and be included in your registry?
Oh, absolutely. This Saturday at the 16th annual Pancreas Cancer Patient Symposium, I give a lot of that information that we just talked about.
Is that symposium accessible to people online after the symposium's over? Do you post it?
Yes, the whole thing will be accessible, absolutely.
Through Jefferson's website?
And through the Department of Surgery website, I believe. It may also be on the Jefferson one. But it's really great because it's allowed us to reach really a national audience with this symposium. Last year, we had a number of people from around the country that got on it.
I know that you've treated people all over the country, really all over the world for pancreas cancer. So that's terrific. Well, Theresa, I'm so grateful to you and to Charlie for all that you do. So thank you so much. You're wonderful people.
Thank you for allowing me to speak. And yes, happy Thanksgiving to everyone.